taking time for your health. The African American Wellness Watch. Trusted information for us, by us. Dr. Mike LeNoir and other experts from around the country and around the world have the latest on how you and your family can get healthy and stay well. It's time for the African American Wellness Watch. Welcome to a special edition of the Wellness Watch. I'm your moderator, George Strait. We're going to spend the next few minutes talking about diabetes, how one can cope with it. It really doesn't have to rule your life. What makes this discussion special is that we've got with us Dr. Griffin Rodgers. Dr. Rodgers directs the National Institute of Diabetes and Digestive and Kidney Diseases, a mouthful. This is the institute at the NIH that pursues the most compelling research to combat the nation's most debilitating and costly chronic diseases. Diabetes is number one on that list. Dr. Rodgers, welcome to the program.
Thank you for having me.
Dr. Rodgers has led the NIDDK for 17 years and is one of only 2 African Americans to lead one of the 27 institutes and centers at the NIH. Again, Dr. Rodgers, it's really an honor for us to have you on our program. Of course, the pilot of this program and this effort is our executive director, Dr. Mike LeNoir.
Hi, welcome to our program, Dr. Rodgers, and thank you so much for taking the time from what I know is a very busy and engaging schedule. The issue of diabetes in the African American community, somewhat of a paradox. There's so much information out there that you would think that everyone who had diabetes would know early on and would intervene to take steps to reduce it. And perhaps maybe we're not messaging exactly right. And so what we attempt to do today is to ask a few questions that we think our audience might ask had they had the real opportunity to get anywhere near your office. So thank you again for coming. One of the problems is how can people recognize that A, they might be at risk for diabetes or they might actually have it?
Sure. Well, there are many factors that increases the chances of a person developing type 2 diabetes. For example, having a family history of diabetes or being overweight or obese, being African American, Hispanic, Latino, American Indian, Alaska Native, even Asian Americans and Pacific Islanders. Not getting enough physical activity increases your risk. As you know, during pregnancy, a substantial percentage of women will develop a condition called gestational diabetes. And having gestational diabetes puts you at higher risk. Having high blood pressure also, having prediabetes, which of course is a condition in which your blood sugar isn't high enough yet to be classified as diabetes, but it's certainly higher than normal. And then, increasingly we're seeing prediabetes and diabetes in younger individuals under the age of 35, probably driven by the overweight and obesity crisis that we're having in this country. And that's been steadily rising for the last 20 years. So if you fall into any of those categories that I just listed, the next time you see your healthcare provider, in case you don't know, ask them whether you should be tested for the presence of either diabetes or prediabetes.
And then that's a good question. And it brings up basically 2 concepts. First of all, what's the difference between diabetes and prediabetes?
So in diabetes, of course, it's traditionally done by doing an oral glucose tolerance test. More recently, people have used a test called the hemoglobin A1C or the A1C level, which tests or gives you an estimate of the average blood sugar over the last 3 months. And the numbers are now been around sufficiently long enough that algorithms can tell you whether you either have sort of a normal range of blood sugar, you're in a pre-diabetic range, or if you have frank diabetes. So either that oral glucose tolerance test or more recently this A1C. Now, in terms of testing, it's a fairly simple test that can be done just, obtaining a blood sample.
And another part of that question is so often what we've identified, the African American Wellness Project, is that physicians don't often ask sufficient questions to either get information about wellness or even when people have illness.
Mhm.
What are some of the questions that people should ask that will trigger their own providers to at least consider diabetes?
Sure. Well, certainly if your listeners hear that range of risk factors, they should certainly ask your doctor, am I at risk for, or should I be tested for prediabetes or type 1 diabetes? What's a healthy weight for me? Because I understand that that weight has something to do with that equation. What kind of physical activity would be best for me to prevent or to delay the onset of diabetes? Can you help me or assist me in making appropriate dietary changes that might help prevent or delay type 2 diabetes? And then the other things to keep in mind are the conditions or circumstances that have, an effect on your blood vessels, which is really where diabetes manifests all its substantial complications in terms of the eye disease and the kidney disease and other diseases. Two other issues that need to be co-managed are your blood pressure and your cholesterol. So you might want to also ask your doctor, have you tested my cholesterol level, and should I be on treatments for that? And what about my blood pressure? Am I in a good range or not? And then finally, as we pointed out, a lot of these things run in families. So how can I help my family stay healthy? Or a few questions. And it's good, to write, as I'm sure you tell your patients, if you come up with a question that you think about, write it down so that once I see you in the office, you don't say, boy, it was something I was going to ask you, but I just forgot now. Write it down so that you have that present with you.
One of the interesting things that I'm seeing, maybe not so interesting, as a pediatrician, is the tremendous numbers of young children who are coming into office grossly obese.
Mhm.
What should parents be asking about diabetes prevention for their children? I always say that dietary intervention has to start at a very early age. A
Absolutely.
3-year-old can't drive you to McDonald's, but McDonald's is full of 3-year-olds
That's
and
right.
increasingly large 6-year-olds
Yeah.
and 9-year-olds. So what should a parent ask their doctors about screening for diabetes and when?
Yeah, no, that's a very good question because as I mentioned in the introduction, increasingly we're seeing what we used to call when we went to medical school adult onset diabetes occurring in kids 10, 11, 12 years of age, again, often associated with having excessive weight. And the problem with diabetes in kids, type 2 diabetes in particular, is that it appears to be refractory to the common medicines that we use for adults with type 2 diabetes. But secondly, the complications seem to be occurring much earlier in the stage of their condition. So the things that they should be asking their doctors, should he be tested? He or she should be tested for diabetes. Does she have diabetes or prediabetes? And a list of the same things that we mentioned before. What kind of diet, restrictions should they be on? How much exercise should they be getting? How much sleep they should be getting? That's a third leg of the stool. Not only exercise, physical activity, and diet and eating, but also sleep. It has a major contribution to not only being overweight, but also your blood pressure and blood sugar.
We're
So
talking with George.
if I can ask a question about sort of living with diabetes, if you will, there's so many complications, eye complications, and all the rest of it. What's the role of say insulin in treatment, and what about the new drugs? What are the consequences if you don't keep up with some of those medications?
Yeah, well, as many of your audience probably know, insulin is the hormone that's made in the pancreas to help the glucose in our blood enter our muscle and fat and liver cells where it's used for energy. And as long as the pancreas is working okay, it makes enough insulin to overcome the cell's weak response to insulin that occurs in people with type 2 diabetes. They're in a state of what's called insulin resistance. Your blood glucose will continue to remain and stay in a pretty reasonable range, but at some point, your body just can't keep up. And at that point, insulin resistance does in fact set in, then the blood sugar goes up. So some people with type 2 diabetes, though, can take medicines to help their body either make even more insulin or release more insulin, or have the insulin that's being used be more effective. But at the end of the day, some people with type 2 diabetes may need to take insulin to help control their diabetes.
Can I ask this question about recent articles in the New Journal? Other journals suggest that Ozempic is all the rage. These new drugs for weight loss are all the rage, but these new drugs do help people on insulin reduce their insulin needs, don't they?
Well, yeah, some of the drugs, but one has to be very careful. Certainly, Ozempic and some of the other GLP receptor agonists are not recommended for people, for example, that have type 1 diabetes, who are in a sense insulin dependent. It certainly has a very effective role in weight loss management, and it may actually allow for people who are on medications to reduce their need for some of those medications. We've heard a lot recently about these drugs. They're general class called GLP receptor agonists. At the doses approved for diabetes, these drugs not only lower blood glucose, but they also reduce weight by about 3 to 5% of the initial weight.
So you outlined a lot of things that we can do to prevent diabetes, and interesting things about how they can manage diabetes. Doesn't have to rule your life, though, does it?
That's right. In fact, increasingly in the sort of the medical care space, we are really sort of advocating for patient first language. We often hear people refer to patients as a diabetic patient or asthmatic patient. It should really be a patient with diabetes or a patient with asthma, because a patient really should not be defined by their medical condition. And so, there are many medications that are currently out there, including, again, standard therapies that have been around for a while. There are even new therapies that you hear about, the so-called SGLT2 drugs like Januvia and others that not only have an effect on lowering your blood sugar, but also have profound effects on lowering your risk for heart disease and kidney disease. Mm-hmm. So there's a list of drugs that are there. And again, most of these drugs have become available due to decades-long research funded by the federal government.
It seems that the future for folks who are diabetic can be bright with new medications and new ways of thinking about how to deal with this disease. And we've talked about a lot of them on this program, but there's a lot more, and I know that a lot of that information can be found on your website, right?
Oh, absolutely. NIDDK has resources for healthcare professionals about talking with their patients effectively about both prediabetes and diabetes. For example, there's a teach back method, which is sort of a quick way for healthcare team members to check how well their patients really understood the message and the information that's been provided. For example, a doctor can ask their patient to state back in their own words what they heard the doctor say. Another good resource is the CDC, Centers for Disease and Control and Prevention, has a health literacy website which discusses plain language principles and provides plain language alternatives to common medical terms. And it does tend to dispel some of the misperceptions that are out there as well. Healthcare providers, I think, should also avoid blaming or trying to identify where patients may be lacking. They should really ensure that the patients leaving the doctor's office understands what they what they themselves can do, and really empower them to do this. And that's the message I think we want to leave with patients.
Plain language. It sounds like a plan. Dr. LeNoir, you want to close this out?
Well, I want to certainly thank Dr. Rodgers for giving us so-called the view from the top in language that people could understand. It's still a puzzlement to me that with all the information out there about diabetes and messaging and attempt to educate the public, that we still have so many people who avoid, who don't avoid the risks. And we see increasingly numbers of children with increased weight regard and what you would call the extreme obesity category. One final question, if George will permit me, before we close. Where are we going wrong with our messaging? What can we do differently that will make us more effective?
Yeah, I think we really need to meet people where they are. Obviously, people, certainly in different contexts, get their reliable information from people who they trust. Oftentimes, that's a healthcare provider, but it might be, teachers. A number of my sister institutes are using barbershops to get out health messages. You want a reliable source. You don't necessarily want to go on the internet because there are certainly groups of people who are willing to sell almost anything. And in that regard, I would invite people to visit our NIDDK website. Just Google that and you can get it. Or they can follow us on social media. And when I say meet people where they are, generally younger people tend to be more attached to social media than for example, searching websites. Our social media tag is at NIDDK.gov, and they can get more information and resources on what we've discussed today.
All right. Well, thank you so much again for taking the time. Thank you for George for putting this program together. And I want to say, as we always say, and this program emphasizes that health is your biggest asset. So protect it.
Excellent.